Well, thank you everyone for attending this morning's meeting. I want to especially thank our speakers and panel, and needless to say, John Meservey for his moderating, and Stan and Teresa for all of the hard work they do putting these together. I am sure we'll all look forward to this meeting as well as our next one in the fall. So without any further ado, let me introduce Teresa. I believe you wanted to say something.
Yeah, just a quick thing. Just a quick thing. I've been collating all the meetings and all the attendees and all the speakers, and we have had over 60 people speaking on these calls. I just want to really thank you for everybody who's contributed, and we're always reaching out to have more people, but I just want to say thank you. And just some quick housekeeping. If please turn off your speaker and your video unless you're part of the panelists, and we'll be looking at any questions in the chat. If we can get to them, we will. But thank you very much. That's it, John.
Okay, John Meservey here. Thanks for joining us this morning. And I'm delighted to introduce Dr. Paul Bittinger as our first speaker today. And let me give a brief introduction about Paul. Paul holds the MGH Endowed Chair in Emergency Preparedness and is the director of the Center for Disaster Medicine and vice chairman for emergency preparedness in the Department of Emergency Medicine at Mass General. He's also the director for emergency preparedness at Mass General Brigham. Paul serves as the director of the Emergency Preparedness Research Evaluation and Practice Program at the Harvard T.H. Chan School of Public Health and holds appointments at the Harvard Medical School and the Chan School. Paul's work requires that he operate across the horizontal and vertical structures of our hospital network, and that gives him a very unique perspective on our operations. His other eye is on external events and their potential to impact our operations. I had the great personal pleasure and good fortune to get to know Paul and learn about his, the invaluable work he and his team when both of us co-chaired MGB's Resiliency Master Plan work a few years ago. So without further ado, Dr. Paul Bittinger. Thank you, Paul.
Thanks so much, John. I would love it if my work became inevitable, but I'll try and make it valuable in any case.
It is inevitable. Unfortunately, we're heading in the wrong direction, but anyway.
Yeah. So let's see. It looks like maybe you're seeing the trying to figure out which view. Are you seeing the correct view of the slides? No. You're seeing them in presenter mode?
We're seeing them in presenter mode. At first we saw it in the full screen, but
oh, you did? Okay.
But right. Then it went to presenter.
Got it. Let me try and switch that back then. Sorry about that. Very much want to try and show you the correct version. Apologies for the technical issues that should be solvable by now. Okay, and now they're in the correct view?
Yep.
Yes.
Great.
Thank you. Sorry about that. All right, so thank you so much. I'll try and keep this relatively brief, but it's a great pleasure to join you all, and I really thank you for thinking about these issues. You know, John and I, and actually Sarah and others on this call have been talking about some of these things for a long time, and I am a huge believer that the built environment and our spaces really influence the kind of care we can deliver in the safety, certainly in pandemics, but in a number of other emergency and disaster scenarios. And so just really appreciate everyone's thought and attention to this. I've been privileged to listen into several of these conversations and always find them very helpful. I was asked to talk about four things, some of the operational processes that have come out of COVID that we should think about carrying forward. Thinking about how infection control overall now is really influencing design now that we are at the place we are in the pandemic. Thinking about what we've learned in terms of either retrofits or new construction through this pandemic, and then lastly thinking about the regulatory environment. So starting with some of the things we've had to do on the fly during the COVID pandemic that have been really under emergency conditions, but really are things we probably need to consider going forward or on this slide. And I know some of this is ground that's been covered in some of the previous discussions, so I'll try and hopefully build on it rather than recreate the wheel. I think, that we have learned, not just with COVID, but with so many diseases, obviously monkeypox now is the current one in the news, that high consequence infectious diseases, emerging infectious diseases are with us to stay. And that portals of entry, particularly the emergency department, but not only the emergency department, it can be urgent care centers and even primary care practices, have to have an ability to rapidly isolate patients. As soon as a high consequence infectious disease or an HCID gets on the differential diagnosis of the nurse who's doing triage or the provider who's doing care, you have to at least be able to get the patient into a closed door environment, even better if it's got negative pressure or other appropriate air handling. The CDC has a model they call identify, isolate, and inform for all high consequence infectious diseases. This came out of the Ebola outbreak in 2014. And identify starts with asking the right questions. And we've been building a lot of new content into our triage algorithms so that nurses ask now about where you've been, where you've traveled, what symptoms you have, so that they can identify these cases a lot faster than we otherwise historically have. But after identify comes isolate, and really, again, making sure that close to triage, close to those portals of entry, somewhere around the arrival sites at our institutions, we've got safe spaces to isolate patients and deliver care. Because if you have to march someone through a busy emergency department to get all the way back to your isolation space, that's not quite so ideal. And of course, we know that many of our urgent care centers and many of our primary care practices really are light on closed door rooms or appropriate spaces where you can isolate a patient. And it's definitely not practical to assume that every urgent care, every practice is going to have a negative airflow space, but at least a closed door room where the airflow is not the same as the common clinical environment, I think, is important. Secondly, my system, lots of systems during the height of the COVID pandemic created special clinics that were dedicated to the care of COVID patients. And whether that was in the rapid screening and care of those patients, sort of an urgent care center for patients with COVID-like illness, or we actually also had it as a specialty clinic space for patients with COVID. So in other words, you just had orthopedic surgery, but then got diagnosed with COVID. In earlier days, we had a special follow-up clinic so that you didn't go to the general orthopedic clinic, you would go to the COVID follow-up clinic, and everyone there was COVID positive, and the clinicians would rotate in and out. So we'd bring in the orthopedic team to see you in follow-up for your surgery, or we'd bring in the cardiologist to see you in follow-up from your recent hospital admission. And what it was is a way, again, either for patients who are presenting with illness that seemed pretty consistent with COVID, or for a way to follow up patients with known COVID illness, that we were able to minimize the risk exposure throughout the rest of the institution. And I'd say until we had widespread vaccination, that was a really, really useful strategy. It made it much easier to see non-COVID patients in our primary care clinics. It made it much easier to see non-COVID patients in our specialty clinics. And so, these are likely not the sorts of clinics that will be up and operational year round. But for that next outbreak of disease, for that next pandemic, having the ability to rapidly pivot and create a space that can be dedicated to the emerging infectious disease, I think, is important. And there's certain design characteristics that are really important for that kind of a clinic, right? It's got to be accessible from the outside. Again, you don't want people marching through the center of the hospital and going all the way deep into the bowels of the institution before they finally reach the door of the clinic. That sort of defeats the purpose. And so relation to outside entrances, the ability to screen, the ability to sort of divert traffic to get to that kind of a clinic is important. So just, again, how quickly we can find and isolate those patients, how quickly we can create dedicated resources, I think is a lasting lesson and something that's been touched on a little bit before. We've talked a lot about security in a couple of these meetings, and I will tell you that of course related to COVID, but unfortunately related to a lot of other things just continuing to happen in the world. I think designing facilities that can rapidly change their security posture in a variety of different ways is important. I think when I last spoke to you all, talked about the ability to rapidly lock down and go into a secure posture, I think is really important. And, tragically, we just are seeing really awful rate of increase in the rate of mass shootings in this country. And I think, healthcare facilities are clearly not immune. We'll talk about targeted events in a second, but we have to be able to lock down just like a school can lock down or something else. And really thinking about that for all kinds of healthcare facilities is important. I'll tell you that, it's not just kind of a binary open or closed or lockdown or not. It's really enhanced or not. As many of you may know, with one of our hospitals, the Brigham and Women's Hospital, became the focus of both neo-Nazi protests and some right-wing political groups that had a specific concern related to patient care, where there were some very, very heightened tensions and a lot of security concerns for the staff, for the patients, for others. And the ability to go to a much more secure, high screening environment where you go to a more limited number of entrances, which obviously causes huge problems for screening and flow, both for visitors and for staff, and to really be able to maintain a heightened level of awareness without completely paralyzing your institution is really, really important. And so, just like obviously, public stadiums these days go from being able to have lots of entrances to a few entrances with high screening, I think we have to do the same with our healthcare facilities, depending on what the threat environment is, and that threat environment's dynamic. There are specific threats that will happen in one clinic or for one hospital that will transiently require some increased attention to screening, and then be able to fade back more towards normal operations. Visitor management, again, I know you've talked an awful lot about it. For those that are interested, there's an interesting New York Times op-ed today from Daniela Lamas, who's an intensive care physician at Brigham Women's, and she talks about the fact that the hospitals have not yet gone back to fully open visitor policies and may never, which I think is right. But as you've seen, we definitely go between more open and more restrictive as each of the waves of COVID has passed through our community. And I think it is incredibly labor intensive, and it's really, really disruptive to go back and forth between more restrictive and more open. I think we really have to think about how the facility supports that. None of us really has the staff anymore. We're under such staff constraints that we can do this only with people. And as you know, and I think you've talked about, during, especially inclement weather, when we get huge lines of people trying to come into the hospital in January or when it's raining, that also is not good. And so thinking about how we can go to more restrictive visitor policies, which I think will be intermittently part of the future, that constrains the number of visitors we get. If we go to limited visiting hours, 11 to 4 or something, puts a larger volume of people in a smaller amount of time, have to think about how we safely get those people through screening and get them into the institution. We definitely need to think about how the facility and the space facilitates screening better than it does. A lot of people have thought about kiosks or other things where you can have the visitors do a lot of it themselves, as opposed to, again, requiring manpower that they can attest to not having symptoms. We can keep track of how many visitors are coming for which patient and help us with some of those items as well, but also help us with throughput, just so we don't have the large crowds, particularly right when visiting hours start, that have been such a challenge for many folks. I think we need to think about other locations. Many of us have had to do a lot of the screening only at the front entrance or one or two entrances. And again, that certainly creates a flow bottleneck as well as a challenge for the workforce that we have there. I do think from a security perspective, also thinking about what other needs we have for screening during these times of heightened awareness. For the most part, our facilities do not embrace use of metal detectors or other sort of physical screening the way you have at an airport. But I think continuing to involve your security consultants about what ways, when we're in a heightened security posture, we can marry infectious disease screening with security screening of visitors as they arrive is really pretty important. In terms of vendor management, you may or may not know, but hospitals are actually getting more scrutiny from the Joint Commission these days about making sure their vendors are compliant with vaccination and other infection control policies. So we, for my system, require all of our vendors to have the same vaccination status and boosters as we do for our employees. And it really, when you think about the number of people that come in, from service technicians for equipment to other vendors, it can be really daunting to try and manage them, since they're obviously not part of our HR systems. Thinking about kiosks or separate entrances where they can go through the screening and themselves attest to the fact that they meet those same requirements, can help hospitals attest to the Joint Commission that they are ensuring compliance. Joint Commission's made it reasonably clear that just saying you have the requirement but not making some attempt at verification is not good enough. And to try and do it at the point of entry, or to be able to facilitate it again with technology like kiosks is something that's probably a helpful solution, as opposed to relying on the manual process of either working directly with the HR departments of those vendors, or trying to do it person by person as they arrive. We've talked a lot about surge, but I feel like you can't possibly talk enough about surge, and I hate to say it, many of you know this, but surge is much worse than it ever has been. We have more than 1,000 people in Massachusetts hospitals currently than we've ever had before in Massachusetts hospitals. My system is at record levels of crowding in essentially every hospital. That means our emergency departments are more full. We have more people in the hallways. We have record numbers of boarders. Hospitals are definitely more full than they ever have been. And I think we have to both acknowledge that for the foreseeable future, this surge state is going to persist, and that, God forbid we go through again another Omicron wave, another surge wave this coming fall and future winters. There's just always a need. So I know you've all talked about before things like double head walls for single patient rooms. I think for monitored hallway spaces, for the ability to find new places to safely care for patients. You just cannot ever be out of the thought. And I hate to say it, because as soon as we identify these spaces, we use them. In my emergency department, which has about 55 beds in it, routinely, we have 50 to 60 boarder patients who are awaiting admission at 7 a.m. every day. So more patients waiting admission to the hospital than we actually have physical beds in ED. And it's not unusual for us to get into a census of 180, 200 patients in a 55 bed ED, all present at one time. And, those are levels of crowding that we've never, ever had before, but they're the reality. And we have to find ways to deliver safe care, while hopefully at some point from a health policy perspective, we figure out how to decrease this crowding. Telemedicine, again, I know you've talked an awful lot about telemedicine, but I think there are a few things that are really important to think about. It is a part of the inpatient care environment, I think, or will be, as much as it's a part of the outpatient care environment. Again, facilitating how patients in their rooms can communicate with, of course, family and loved ones, but also how can we increase the efficiency of care with our consulting services. And particularly during outbreaks of new high consequence infectious disease, we used a lot of iPads on poles that went into patients' rooms, but how can that just be more built into the room so that if we have to have a lot of our consultants do virtual consultation while in the inpatient environment, I think that's worth thinking about for sure. The other thing is, I think we have to think about telemedicine and other technology as a way to support our staff. Again, I don't think any of you is surprised to know that we are under greater staff strain than we ever have been in the healthcare system. I mentioned already we have more than 1,000 patients. We are down, depending on what numbers you look at, 15 to 20% of the healthcare workforce from our baseline staffing levels pre-pandemic. And so we have fewer staff and more patients, and we have to think of how technology can make it easier for the nurse to deliver bedside care, for all of us to be able to do our jobs, because the strain on the healthcare workforce is extraordinary and real. And both for the sort of mental health and stability of the workforce, but also just for their ability to get their job done. Trying to think of what technology supports we can build into that environment is important. Last thing I will say on the operational processes side is not actually a direct clinical care comment, but more of an operational one, which is most of us went to hybrid meeting environments. Obviously, right now we're all meeting virtually. But more and more, we've been coming back to having sort of some in-person, some tele or virtual meetings. And, for example, a lot of our educational conferences for our staff have some people in a conference room and some people who come in from home on Zoom meetings like this. And just like, for the most part, I think people in education hate the hybrid meeting environment, because you're either talking to the people in the room or you're talking to people on the camera. And whoever you're not talking to is kind of unhappy with the experience, because it's really hard to do both well. I think we need to think about how we do better with the hybrid environment. I think it's here to stay. Obviously, many of us have people who are working at home, and we're trying to have working meetings. But especially with the clinical staff, some of them are on site, some of them are going to be at the hospital and some want to be in the hospital. And so just thinking about how our built environment facilitates, both business meetings and educational meetings in a way that works for people who are in the room and people who are virtual, I think is really important. Pivoting a bit to talking about infection control and what have we learned that's part of basic design. Everybody's been talking about airflow now for a couple of years, but I would just remind everybody that I think that the focus should be on airflow everywhere, and this includes in your administrative spaces and others, that really we need to be making sure that we're meeting certain air change standards, even in administrative or back office spaces, not just specifically patient care rooms, because I think that is one of the ways in which we can assure our staff a healthy and safe work environment when they're physically present, decrease obviously the need for masking while they're at their workstations, and to feel confident in the safety of their work environment. Lots and lots and lots has been said about increasing airborne infection isolation rooms wherever you can. I'm a huge believer in this. At Mass General, we have made the decision to make all of the rooms in our acute area, which is the sickest part of our emergency department, it's a 17-bed area, to make them all negative pressure rooms, so that when needed, we can put a high consequence infectious disease patient in any one of those rooms. Not every room has an anti-room. We tried to figure out where we could get anti-rooms in. The decision ultimately was just it's better to have negative airflow than a full anti-room if we can't do it from space. Even if you can't do a full airborne infection isolation room, thinking about pressure differentials just to make sure that the hallway and the nurses station area is not sort of getting fed with airflow from patient rooms, that in general there's an ability when you need to, or at least to be able to switch to that ability to have the rooms be slightly negative with relation to the hallways and the common spaces for high consequence infectious disease events. We're all talking about how to balance all these goals with airflow and negative airflow, and particularly with use of outside air with the energy and carbon goals we're trying to meet. There are real heating and cooling consequences to the amount of outside air that we're using, and thinking about the balance of outside air, thinking about where we incorporate filtration is a big deal, and should not be lost. I think that's a very, very important consideration in all this. Basic cleaning of spaces. I know this is something many of you have been thinking about for a very long time, but simple things like in one of our behavioral health spaces where we put in rounded corners into the edges of rooms as opposed to rectangular corners makes them a lot easier to clean, and you just don't have those little nooks and crannies so much that are hard for the environmental services staff to be able to adequately clean. And I think just again revisiting some of the common things that we can work on to just make room turnover faster, easier, safer, to make it easier to assure that we have good, clean spaces, I think is really important for design. And just again, those simple little things of rounding off a corner can actually make a substantial difference in terms of the room hygiene. There have been a bunch of different lessons about how we do construction in the pandemic era that maybe will actually be helpful going forward in general. I think in our system we've certainly learned that you can have a lot that's done remotely, that the on-site planning meetings, even the on-site walkthroughs, either with virtual walkthroughs or Spot the Robot Dog has been used from Boston Dynamics, that everybody's probably seen the Boston Dynamics dogs used as a way to do a video walkthrough for contractors and for others. I think we're doing more and more off hours as well. Facility density is a huge thing. I probably should have mentioned that a little bit more on that first slide. We have struggled in my system, but I think for most systems, balancing the desire to have more people on campus. We want more visitors. We want patients to have their families near them, with our need to ensure we have space for our staff. And so, one of the construction thoughts is to certainly try and make break rooms bigger whenever you can. And I know that's an extraordinary challenge just because there isn't space for it, but a lot of the outbreaks of COVID have happened in break rooms where people have their masks off and they're right next to each other and they're eating and drinking. So we've tried not to have people in break rooms. And I know, again, from a physical plant perspective, it's hard to get break rooms as big as you want them. But you have to have dedicated areas where people can eat and drink. Your staff can eat and drink and be 6 feet apart from one another in an unmasked fashion. And part of the challenge we've had with that is that often our staff and our visitors use the same spaces for eating and dining. And it's actually been a legitimate reason to have visitor restrictions in our system, that we just can't have more visitors because we don't have enough staff to support us, or enough space to support our staff and what they need to do. And so I do think we need to think about how we can look at retrofits and new construction to support different use of space and segregation of space, so that we have more clearly designated surge staff support areas, especially eating and drinking areas, versus public eating and drinking areas. And forgive sort of the digression there, but I'd forgotten to mention that a little bit before. I think other possible lessons for from the retrofit is that the more and more you can do offsite, the better for prefab or modular construction. That just decreases density. Everything that decreases density and keeps the need for people to be on site in your facilities, in your space lower, is a really good thing. And this has nothing to do with COVID, but I will say this is from our system. And John and I have spent probably, I don't even know now, 4 or 5 years talking about this. But we undertook a very large project to look at the climate vulnerabilities of our system, and identified a huge laundry list of heat stress, wind stress, flooding, other risks from climate change. And in total, I think we had more than $300 million worth of capital projects that we need to look at. Clearly, we can't attack them all at once, but we did make the commitment that every single time we're doing a retrofit or we're touching an area, we're going to be trying to address the climate vulnerability of that space, whether we have a chance to make it less flood vulnerable, or to change its window ratings for heat gain, or for wind speed issues, or for driven rain issues, all of that. I just think there's a substantial need to make our healthcare environment more resilient against climate. And while we're thinking about infectious disease resilience, and frankly, just in general, when we touch our spaces and have the chance to upgrade them, I think not just thinking about COVID and infectious disease, but thinking about climate at the same time is really, really important. And then lastly, just to touch on the regulatory environment, I think there's some interesting good and bad things here. You're well aware that hospitals worked more together than they ever have during the COVID environment, and shared a lot of best practices and what was working and was not working. And I think as a group, the hospitals had more conversations with DPH and with state regulators than ever before. And the good news is, I think we also had an unprecedented number of regulatory relief actions and flexibility as the surge happened, because we had to. We had to open up new ICUs and take spaces that weren't intended to be ICUs, turn them into ICUs. We had to have use of non-clinical or non-licensed spaces before to deliver clinical care. Overall, I think that will continue. We just recently got an extension from the state DPH here to allow us to continue to use certain surge spaces, just because they understand the capacity crisis we're in within healthcare right now. That's good, but I think, again, over time, there certainly will be attention paid to how well the environment supports the care that's being delivered there. So thinking about, when you design a surge space, how well can it be, or how much can it be similar to what you would otherwise want in the clinical space, I think is important. When you design a new med surge unit, and I do find it ironic, by the way, that med surge is medical surgical, and lots of people, so it's MED-SURG. Lots of people these days are spelling it MED-SURGE, which I think is just a reflection of the surge that's often done and needed in those spaces. When you build a new med surge unit, intended for floor care, at least some of it should be thought of as surge ICU space, and thinking about, not designing to ICU code, but what can you do to make it able to accommodate critical care better. That, I think, helps you facilitate some of those expedited approvals that allow you to change in crisis. I'd point out that OSHA has been paying a lot of attention to medical staff safety, and a lot of it has been on the use of respiratory protection equipment and PPE. We found a lot of challenges with access to PPE for staff. And so thinking about how the built environment can make it as easy as possible for staff to access PPE is important. But I think also just, thinking about those ways that you can prove that the airflow, that the other design changes we've talked about might make sense and might be attractive to hospitals in terms of what they can say to OSHA. And last thing, I mentioned already, identify, isolate, inform algorithm from CDC, which is what we do to make sure that hopefully a high consequence infectious disease patient doesn't infect medical staff, doesn't infect other patients. There is some talk, and I'm actually part of some of it, to think about this the way we think about acute stroke patients or acute heart attack patients. There are standards when you come to an emergency department that you have to have an EKG within 10 minutes in order to identify a heart attack, or you have to have a CAT scan within a certain number of minutes to identify a stroke. And the built environment, I've worked with Sarah, I've worked with a couple of you on this to support those kinds of regulatory changes has changed a bit. I think if ever the federal government does say you have to be able to identify and isolate a patient within X number of minutes, there will be even more pressure to having spaces available near points of entry to help that. So those are kind of my broad thoughts in the 4 categories. I hope they're helpful, and I'm definitely eager to hear the panelists' discussion of some of these topics and hear where you think we can be going.
Thank you so much, Paul. That was tremendous insights, many of which, as you mentioned, we have been discussing. I think there are some new ones in there, and I think there are definitely some challenges. I think regulating access to the hospitals is not something we've done historically. And, I'd look at places like Mass General and the Brigham, where the community absolutely expects access through those corridors from one end of the campus to another. And they take that as a right, and so the notion of restricting their access and even closing those access points is not only politically challenging, but I think is going to affect many of us. I had a question that's sort of tangential to something you were talking about, and it has to do with the 6-foot spacing around around unmasked individuals, and whether that's the standard that we've established for COVID. Is that a standard that we have reason to believe is going to apply for other infectious disease coming down, something short of Ebola? But if we plan on the 6-foot spacing, is that going to work for other future?
It's a really good question. Yeah, no, it's a really good question. So to put it in context, I'm not an infection preventionist, but I spend so much time of my life with them that I can channel them at least. And I think, there are more or less 4 kinds of precautions. Many of you know this, that we use when we categorize how we isolate an infectious patient. There is airborne, which of course is the airborne infection isolation room, and that's a disease like measles or others that are transmitted clearly with airborne particles that linger in the air for hours. Then there's droplet, which is influenza, and actually I don't want to get terribly political. There's obviously been so much said over the last couple of years about how COVID is transmitted, but still the vast majority of COVID transmission occurs in short distances in 3 to 6 foot droplets. And it's not to say it doesn't linger in the air and it can't happen otherwise, but the majority of respiratory illnesses are transmitted by droplets, which means that's that 3 to 6 foot range. And there's nothing absolutely magical. You all know this about 6 feet. It's just that that's where really the vast majority of transmissions falls off. Now there's contact, of course, and then there's just standard precautions. But very few diseases truly are airborne transmitted, and the vast majority of respiratory infectious illness is in that droplet range. So that's where that 3 to 6 foot comes from. But we can't guarantee that, of course, the next pandemic won't have airborne transmission. But that's where we're thinking. Pandemic flu, that would work the same. That same distance works for that as well.
Thank you. Teresa, do we have questions, or should we get on to the other panelists?
I don't see any questions yet, and just a note that Paul Cantrell is unable to make it.
Okay.
So,
All right. Well, let me thank you very much, Paul, and I'm sure there will be questions. Let me move to the next panel, and we have 7 panelists, not including Paul. We have Dave Duncan, who's Assistant Vice President, Facilities Management at Dartmouth Health. We have Nancy Hanwright, who's the Senior Director of Real Estate and Planning at Boston Medical Center Health System. We have Kathleen Hilke, VP of Facilities and Support Services at UMass Memorial Health. We have Kirsten Waltz, Director of Facilities Planning and Design at Bay State Health. We have Sarah Markovitz, a principal at MBBJ architecture firm, and Sean Bryce, who's the president of TCI, Thompson Consultants Inc., MEP engineering firm. So thank you all for joining us. And
John, would you like us to put the questions up?
yeah, why don't you do that? Thank you, Teresa.
Harani, can you do that, please? So I think it's slide 4. There you go.
So these are 4 questions that we sent out in advance. Obviously, you can address any of these questions directly, or if you'd also like to speak to any of the points that Paul made, I'm sure it'll be just as interesting. So anybody have their hand up? I can't see, but if somebody would like to jump in and begin talking, that would be great.
I can start if no one is volunteering.
Go ahead, Kathleen. Thank you.
Thank you. So, you know, I was started listening to Paul's presentation. It was excellent and really touched upon a lot of the things that we've done and considered. One thing I did want to mention, it really gets to changes that you make around air quality, air control in times like these. And one of the struggles that we had, you know, like many of the institutions here, our campuses are made up of buildings with different mechanical systems ranging in eras, you know, from the 60s to the, you know, recently constructed in the last couple of years, in different types of HEPA filters and different ways you control them, whether it's, you know, automated or you have to go in with a wrench and make changes. And we did exactly what Paul talked about, right? We tried to be negative pressure, increase outside air, at least make it negative flow. But, you know, we really had a situation where we had some units that we could make negative pressure, truly negative pressure. Others, what we were just negative, you know, barely negative to the corridor. Others we had to, by room, others we had to make entire units negative, right? And that required staff to wear PPE full time when they were working in that unit. I think as we move forward, and one of the issues with COVID is that it changed so rapidly, right? What the CDC was coming and how we were handling it, that the communication with the staff is we ultimately created situations where we treated staff differently depending upon the unit they worked in and what we could change from an infrastructure. And that really built a lot of distrust and nervousness and uncertainty, you know, with our frontline caregivers, doctors, nurses, housekeepers, facility folks. And so I really need to think about, you know, when we are faced with these situations and when we're planning in the future for what we can and can't do, I think we need to think about that. And as we start to look at upgrading our systems, really prioritize that piece of it. Because a lot of time and effort was spent really trying to make people comfortable with what facilities was doing. So just something out there, we can't make everything negative pressure. And I don't know that we want to or have that ability, but I think really that was just a challenge that we had. And it'd be interesting to hear what other the panelists' experiences were.
Go ahead, Dave.
Boy, Paul's presentation was spot on, and I'll kind of carry on to what Kathleen just said, but I wanted to talk about 3 things because it really hit home. Boy, the environment and locking down and screeners was a big change. And then I think we realized that it was allowing us to take care of patients better, especially in short staff. And up here at Dartmouth, as the pandemic kind of wound down a little bit, boy, there was a big push to open the doors back up and let visitors back in. So we let some of our guard down and let more visitors in, and still kept the screeners at the door, but just opened more visitors. And it wasn't but 2 weeks, the clinical staff on the units were saying, we're short-staffed, we're dealing with all of our patients, and we're seeing more and more people up on the units without their masks on. And then we double checked that we reviewed that you have to have the mask on in the inpatient units or in the hospital. But once the visitors got in and they were not mask type people, they were off. And then it took the clinical people to try to enforce it. And we went back to reduced visitors hours, more controlling, because it put a big burden on the inpatient units again. So, and we're still in that environment now. Yes, do we make more exceptions to the rule? But with the limited staff, it was challenging for the clinical staff to try to enforce mask rules. So we went back. The second thing was the negative airflow. Boy, we all had, hundreds of fans in inpatient windows and forcing negative pressure. And I'm fortunate up here at Dartmouth that we're in the middle of building a new 128-bed inpatient tower. And we're fortunate enough that they designed all rooms to be ICU level capacity. But the building was going up. The mechanical system was designed and the pandemic hit. And we pivoted and reviewed and made some changes. And we're fortunate enough that without too many big changes, we were able to have every room have the ability to be negative airflow without putting a fan in the room. And, on new construction and new technology, we do have the ability to do sections of wings or an individual floor or an entire floor or the entire building or just an individual room. So we've been fortunate with that. And then the other thing we did in our new patient tower, we designed for the technology thinking out 10 and 15 years out and how things were going to work. And every room is set up for telemedicine so that we can support the clinical staff, but more importantly, physicians can be able to examine any room, any patient in any room at any time. And we're seeing how advantageous that's going to be in the future. So we have a 9-phase backfill renovation when we open up our new tower that we're going to free up existing inpatient units and we're going to go and upgrade. But more importantly, we're going to bring the same level of technology that we put in our brand new building into every single room, including telemedicine in every room, just to be able to help with the staffing of the future, the need and the appropriate use of RNs, but also to have physicians be able to see patients in the room at any time virtually. So those were a couple of my comments.
Hey, Nancy.
Hi. Just to echo what Kathleen was saying earlier, in terms of communications, we really created some tight communication strategies, and part of that had to do with the level of distrust of information that was happening early on in the pandemic. And so creating cross-functional teams that spoke every day about, like, what does having 3 feet or 6 feet apart really mean? When that information first came out, every person that worked in a multi-shared workroom decided they wanted their own office, right? And so that really was not feasible. And so just making sure that we included infection control, emergency management, and that so that we aligned our messaging and explained that to staff so that they didn't feel like different areas were getting different kind of allocation of space, if you will. And I think the other big thing, just as we think about operational processes in the future state, is for us streamlining the entrances really became key not just from a staffing standpoint, but patient screening became streamlined. We had to include less staff because we were able to have flow coming in through 1 or 2 entrances versus multiple entrances. And that is now carried on into being key from a safety standpoint as well. And so, and that is something that we're looking at closely too for the future.
Great, thank you. Kirsten and then Sarah.
Good morning, everyone. A few items I'd just like to add to Dave's piece, just talking about the stresses of the staff, especially on the inpatient units and the visitors. We've gone back, gone both spectrums, and it's really a balance, because we're seeing some units where it's helping tremendously to have the visitors there because you have lack of staff and they become part of that care team. But then a balance of that is if they're not adding value to that piece. They're more, the nurses are managing them, and it's becoming an additional stress for them. So we've been working closely with them, and also the taking a look at technology in how we manage our vendors. We're getting more and more vendors that are coming in. Construction hasn't stopped, and technology, not only for telehealth, that Nancy was just talking about and other things. We're trying to understand how to best manage our vendors so that we can make sure that we're capturing all of their immunizations, we're right up to speed, and that we know when vendors are on site and they don't have carte blanche, and we don't want them coming in through the main public entry. So really desegregating those and working closely with security on that. The other piece I just wanted to add that communication has been key for us as we're seeing the decline, or the stresses in staffing. We implemented a very structured daily management system. Not only, so we have 4 hospitals throughout Bay State Health, and we now have a 4-tiered huddle system that is a daily huddle system that allows us to provide stand-ups, at the unit area, departmental huddles, situational awareness huddles, and then executive huddles. And things get brought up, and it's not only, it's good things that are happening in the units, it's lessons learned, it's, what are we doing about CT, contrast shortage, it's something that helps, just as an example, helps throughout the system. So I think those structures huddles have definitely helped for us throughout the health system.
Sorry, I was on mute.
That's okay.
Thanks, Kirsten.
No
Sarah?
problem.
Yeah.
So just following up on all the great stuff that we heard from everybody so far, and from Paul and from Duncan, just about, I think what we're starting to see is that in new construction, a lot of response to these issues through technology solutions, and whether that's the right way to go or not, I think everybody's planning for it. So everything from this whole issue of managing visitors and coming through, we're starting to see certain institutions who are going to more aggressive ways to manage, more rigorous ways to manage visitor flow through RFID badges for every person who's coming in, and not being able to access like an elevator lobby without swiping your badge and then knowing really who's in the building and where they are. And I realize that's a real difficulty for these big institutions of people on the call here who have 28 entries to their buildings. But I think it's in a combination with looking at reducing the number of entries as a long-term goal, and then being able to manage people. And likewise, one issue that we heard from a lot of institutions was, and I heard this from several of you about communications and different things going on in different units, was that a lot of that communication was done by paper, and different signs would go up one day about what the precautions were and the proper PPE and who should go where, and it was limited. And then those signs would not get taken down when the next level of information went up, and it was really confusing. And I think people are responding by thinking more about digital signs at entries to units and at entries to rooms, to be able to have that information really clearly in front of people, as well as I think what Dave was just talking to about smart screens and TVs that are able to do telemedicine in every patient room and to be able to have distant consult. So we're hearing a lot about from the technology side. And then just one item from the regulatory side. So for some of the work that we're doing now at MGH for the new building is looking at rooms that are storage capacity rooms that can either take, if needed to, take 2 patients if required in that kind of surge, or convert from a med surge to an ICU. And then on 3 floors, we're looking at being able to have all rooms go to negative pressure. And in our recent reviews with the DPH, we are seeing some help with that process, thinking forward to the future about allowing rooms to go to negative pressure, but not necessarily meeting all of the requirements of a standard AII room. So we're seeing some help on that part on the DPH.
Great, thank you. Sean Bryce, are you on the call?
Yes, I am, if you can hear me, John.
I can hear you. I was just wondering if you had some sort of insights as to what you are seeing in your hospital work with regard to increasing airflows and increasing negative pressure rooms, and sort of what the impact is on overall supply volumes, electrical consumption, those kinds of things.
Sure. So what I'd like to hit on are a couple of examples here. One of which has directly to do with Dr. Bittinger, and the other one is Dave Duncan.
Okay.
So the Lunder building itself on MGH's campus, when we set that up, we looked at the ambulance dock and said, in the event of some kind of a mass casualty, the ambulance dock could be an area that they process people that come through, showers, heat, etc. What we didn't realize was that we should be able to divide the ambulance dock system-wise, so that when we do have multiple rooms that come in, such as what they built during the height of the pandemic, could be more easily done. Now, just as a kind of a separate piece to that, as he was saying, the overflow associated with the emergency department right now is immense, and the hospital has tasked us with trying to figure out if we could do additional pre-admission spaces that are out there, similar to what they had for the pandemic, the height of the pandemic, yet more of a permanent type solution. So what it did was it kind of brings us back to a couple of basic questions. And the basic questions are, when you think of different spaces, large spaces, small, whatever, how flexible and how long do you think that you might need to change the purpose of that space? So if you do it from a very rudimentary standpoint, you design the space the way it is, yet you come up with strategies to be able to convert it. And that's a short-term, once over type solution. The second is you have the controls, the ability to do that, but you don't use them. So they're back and forth. And then the third is you just design it that way in the first place. So to Dave's point, basically every space within the new building that he has can be converted to a negative room or a negative wing for what we have. On the second part, with Dave's new building, we've had the opportunity to work on it with him. So he's right. We did set it up so that you can have multiple zones, wings, floors. They have a lot of flexibility in terms of what they can do with a negative area for what's there. And when I say negative, I mean negative directional airflow, not an actual differential pressure for what's there. That's something very different, and that's something that's governed by code for what they have. So that ability is there, and it exists from a variety of reasons, not just the pandemic and the negative, but mostly for life safety. In the event of a fire, what happens is the fire department has the ability to control where they want the air to come from. They also have the ability to control the amount of outside air that goes into it. So those protocols, those metrics are already part of the systems. And in some cases, in some of the older buildings that are out there, you have the same ability to do that. And I noticed throughout the whole process here, a lot of people didn't realize that they had that many additional controls that they could use, albeit using those types of controls could disrupt what the fire department does as their protocol when they show up. But so a lot of these buildings that we already had from inpatient standpoint really did have a lot more control than what was being used. And then it was just a question of, do we put something temporary in, or do we try to use something that's going to be there for the long haul for what we have.
That's an interesting point. I think we all learned a lot more about the capabilities of our buildings once we got into COVID, and obviously we're being innovative, and we're looking at, as you mentioned, some of the life safety systems, and especially smoke evac, and what ways can we harness some of those systems to help address or supplement the conventional air movement systems in the buildings. So interesting point. I think we're almost out of time. I see Madeline has a hand up. Hi, Madeline.
Hi, thanks so much. This was so fascinating, really on point, really current. I have one question, and that is, so I work in infection prevention. I'm really close to the transmission events of the hospital acquired infections. And we really see that semi-private rooms are a risk factor, regardless of whether they're negative pressure or regular pressure. If someone's pre-symptomatic and they have COVID, transmission to their roommate is not uncommon. Similarly, other HAIs like C. diff or other respiratory viruses that are not, or MRSA that are not transmitted by airborne routes, we see those transmit occasionally between roommates. I'm also hearing that new construction, while primarily private rooms, is being built to accommodate surge capacity to semi-private rooms. I think we know that population growth in Boston and everywhere is growing. How, my question is, whether it's for Paul or the panel, how are you kind of reconciling the infection control issues associated with semi-private rooms and the surge capacity? So I know it's a balance, but any thoughts on that would be really interesting.
I'll give a quick answer. It's a great, really good question. I think the only thing we're really continuing to think about is cohorting. That of course we would not cohort suspect COVID patients with non-COVID or confirmed COVID patients, and we would have to rely on the effectiveness of pre-admission testing and cohorting. There absolutely is a flaw in that, as you pointed out very nicely, that it will not pick up all pre-symptomatic individuals. But short of better testing, I think from an airflow design perspective, I don't have a good solution.
I would just add to that. I think, Madeline, you're right. It's not ideal. And it really is a response to situations that arise that are pandemic related or in an extreme measure. I think ideally we would all build individual rooms, and this just substantiates our need as a state to increase our bed demand, right? As we talk about DONs and capacity, it is clear that we do not have enough. And so all hospitals, I think you're seeing now, are doing that work in creating opportunity to build new, ideally private rooms, but designing for those pandemic situations.
Well, all it takes is money, right? And so problem solved. Thank you, everybody. Thank you, Paul, David, Nancy, Kathleen, Kirsten, Sarah, Sean. Tremendous insights today, really fascinating discussion. And as this series of meetings continues. I'm sure many of you will be back and we'll be asking for your latest thoughts and perceptions as to what's going on as we evolve through this unknown state of living with pandemics. Thanks very much, everybody.